All right, we're going to get started with our next presentation. We're going to move to trauma. Move away from mom parts, mostly, I think, to trauma. All right, so we've got a couple of presenters for you from Lifelight. So, and after this, of course, is lunch, which is, for those that are here in person, right out to your left, out that door, up the hill. All right, so lots of questions, right? Looking for lots of questions to get through today. All right, thank you.
Thank you. Hello, everybody. I hear it's a lot colder in here than it was earlier. We did that on purpose so you won't fall asleep. Welcome. Super happy that we can be here today. Appreciate it. We look forward to talking to you about a couple case reviews from the Backcountry. Introductions. My name is Carrie Zabala. I am the Director of Clinical Education at Lifelight. I am a respiratory therapist and a flight paramedic. And my partner in crime here, Shelly, I'll let you introduce yourself.
Hi guys, I'm Shelly. I am a clinical education manager and flight nurse. Everybody can hear me, right? Right? Okay, a little bit. I will project. How about I'll project up?
You guys have a microphone? Because I don't think it's on.
Oh. What about that? Did the power button work? Yes. Okay. If it doesn't work, turn it off and on again, or use the microphone.
Just yell out.
It's there, it's just on the pad.
Let me turn it off then. So we'll just use the picture.
Yeah, it's not.
You're rolling over our heads, it's fine.
Or you doing that? I think you're doing that. So click. Yeah.
All right, how about now? Can you hear me? Excellent, thank you. So a few objectives that we're going to go over with our case reviews. There'll be two pediatric rural case reviews that we're going to look at. We're going to identify some key pre-hospital key interventions and discuss some considerations for these critically injured and ill patients, and a little bit of a difference between approaching it between pediatric and adult. And Shelly is going to take it away with our first case study.
Let me try this now. Can you hear me now? Yes, I hear a no in front. So in back, I'm going to go with it. Thank you. Cool. Well, thank you guys for letting me be here. I'm excited to talk to everybody. I've never presented virtually, actually, fun fact. So if I get a little distracted, that's why. I generally walk around a lot, so I feel a little bit challenged having to stand in one spot. So if I move my arms, that's very normal. I'm just trying to stay focused, which I think all of us are very familiar with staying focused in motion, right? So cool. Well, like Carrie said, so I'm clinical education manager and flight nurse. So I live just outside of Boise, and I cover a fairly large area. So anywhere over from Eastern Idaho all the way up to Pendleton and Eastern Oregon. So I-84 is my friend. I get to see a lot of rural areas, and so excited to share this one with you guys. I think I can say this. This may have been something that I was involved in. So if I don't know the answer, well, I'll do my best. But okay. So what you see here is what you're flying over. I'm gonna take you guys along on a flight with me. So we've got a 35-minute flight to the scene, and we get some coordinates. When you think about where it's at and know the coordinates in this area, it's definitely very rural. Okay. So we do get a heads up that it's pediatric, okay? And we know that from the scene, because we all think about where are we gonna go after this? So our options are when we get to the scene, we can do a 20-minute flight to a level 2 trauma facility. And then there's this got a little messed up, a level 1 trauma center with a 65-minute flight. So on our way, of course, things change in EMS per always, right? So you get an en route transmission of new coordinates. So those coordinates change actually to a small facility. So you're not really sure what your resources are there because it's not a facility you've been to before, but you know that you're going to be there in 5 minutes. Okay, so it's all of a sudden changed a little bit, and we're here now, and what we were thinking is probably going to change. So we walk in the facility and we see a teenage male. He was found in his vehicle after a 911 call. So between my partner and I kind of talking out, we thought with the coordinates, this would be trauma. I know I'm going to have to let you down a little bit. Not all of today is going to be trauma. It will be pediatric though, okay? He was found in his vehicle, attended with a GCS of 3 by the sheriff. And he was transported to this critical access facility by local EMS. That transport was very quick, very rapid, and I think ultimately played a very large piece in this patient's survival. So your differential diagnosis is tell us more. So when you think of a teenager not responding, what does your brain go to? Yes, BG and drugs, okay? So we walk in and it's the same situation we're facing together. He's not responsive. The sheriff does tell us, yes, we found a bunch of bottles in his car full of pills. So when they got there, and I want to highlight the importance of this because I think it's overlooked dramatically. So this patient, I have to slow down because I got to make my slides longer. The key interventions are really what played in his success. And so I want to maintain some focus on that. So position and suction and route. So we know a teenager with a bunch of pills, there could be likely what? Vomiting, right? And so they maintain this patient's airway with BVM and a little bit of suction needed. But they did a really good job of that. They thought, let's protect it. I know sometimes we always go to advanced airway and we think they need a tube. Yes, they may need that definitively, but maintaining that airway patency en route is key because ultimately when we take an airway, what are we trying to prevent? Aspiration, right? So it begins from the start and keeping that airway clean, unsoiled, whatever we can to avoid that end result that could be detrimental to that patient, sans all these bottles of prescription drugs, right? The other key is warmth, okay? They made a very big effort to keep this patient warm. It was up in the mountains, so as you know, temperatures change, and they presume that this patient would be cold. That's usually a pretty safe assumption. I mean, unless you feel their forehead and you're thinking, oh, this is, you know, the rare case where we're fighting that. But out in the wilderness, we're going to assume that most people are cold until proven otherwise with temperature, right? Also oxygen, right? So they administered oxygen and they prevented any singular dip in low oxygen in this patient before he got to the facility. We're seeing that even those 1 or 2 dips in your blood pressure, oxygenation, things that are outside of your parameters really begin to affect that end storm of what happens in the body in your metabolic acidosis. Spoiler alert. And they were also very expeditious, right? So getting that patient from the scene, they brought him straight to that facility where he could be stabilized, okay? And so our job was to continue to maintain that. When we walked in, so the bottle was actually metformin. How many people have heard of it? This should be like a lot of hands. How many people have heard of a metformin overdose? One? Yeah? A couple, okay. Do you know if it was a big bottle of pills or just a few pills? Half a bottle. Adult, child?
Mid-20s.
Okay. Yeah. And so metformin, it's a widely available drug. They can get it out of anybody's cabinet. In this case, it was out of his mom's cabinet, and it was sad. It's like, really? What are we going to expect with that? So what does your brain jump to when you hear metformin? Diabetes, right? So I will ask you a tricky question. So does it directly lower your blood sugar? No, right? So is it technically an anti-hyperglycemic agent? So all of the things that it's doing are meant to prevent hyperglycemia instead of induce hypoglycemia. Unfortunately, when we give a big bottle of this, we've only got a few documented cases to really look at and see what we're going to expect. But those things that you know about it lead you to those key interventions, right? So the end result of too much metformin, we're going to talk about it, visit a couple other points, and then come back to this, okay? So just the key concepts. So you can actually get a metformin-associated lactic acidosis, and this is on top of anything else going on. So it's just going to worsen that storm of the body not compensating for that metabolic acidosis. You can also get this scary thing called refractory vasodilatory shock. Refractory means not responding to anything you do. So we can try vasopressors, but in some cases it doesn't respond in this weird way. And there's some things that, you know, we don't totally know about it because it is an oddity to see it as an overdose. The likelihood of it increasing though as an overdose opportunity, it could, especially as we see it increase, I mean, as it's used more often and pretty widely used already. Interesting thing, when you take too much, you can actually see there's a couple of cases of a hyperglycemic reaction. Yeah, really weird. Nobody really knows how to explain it. If you do know how to explain it, then come do it and I will pay you. Because I'm like, I was kind of talking through it with one of our associate medical directors. He mentioned, he was like, you know, maybe it was like a cortisol response with the pituitary and this, and this. I'm like, oh, my brain hurts. Just know that you can have a hyperglycemic reaction. But the key is really check your blood sugars and check them frequently. And you'll see this in this case as we get to it. You're like, go ahead and get to the patient. Oh, this patient, at least every 30 minutes, if not 15. If not 15, depending on the amount. Because this patient actually took basically the whole bottle. And he's teenager size, so kind of smaller adult size in our brains. But in children, the takeaway, especially if children grab things, right? And it's amazing what they'll put in their mouths, like syringe caps, anything that they see just end up in there. 1 or 2 tablets can actually equal an overdose, right? And kids just have super responsive metabolisms, right? And so that sugar can happen fast, whether it changes high or low, it's going to happen fast. I love this happy little liver. So it wasn't happy, but I wanted to put it on there. So coming back to metformin and how it works, I do think it's important to kind of revisit this because I know we all think it's for diabetes and controls blood sugar, which it is. But there's a few mechanisms in which it acts and prevents that. So it prevents extra production of glucose in the liver, essentially, okay? So that buffer of, yes, my body needs more sugar and I'm gonna push it out from the liver doesn't really exist with metformin. Long term, I mean, initially in my brain, I thought, that's probably not affecting them yet, because I've actually taken metformin for a couple of years to try. And I was like, you know, it was interesting. Some people get low blood sugar, some people don't. And there's a few things that we can't totally explain about it. It does improve your body's sensitivity towards insulin, so like muscular uptake of glucose, etc. And then it reduces the amount of sugar absorbed by the intestines. So it can cause a lot of GI upset. So in your lower overdoses, you'll probably most likely just see GI upset, okay? The other interesting part is you have an increased incidence of metformin-associated lactic acidosis. It's a lot to say. When you're having decreased tissue perfusion, hemodynamic instability, and hypoxic states or serious acute illness. So teenager, because we all said, yes, pills, overdose, vomiting, blood sugar. What else are we thinking? If they have pills, what do we expect there are? Other pills.
Alcohol pills.
Yeah, alcohol, that was a good mention too, for sure. Really any substance, you can see weird combinations.
Energy drinks.
Oh, energy drinks, yes. That's a whole other one. But yeah, any combination, liver disease, kidney disease, heart disease. If you're already sick to begin with, this slide essentially says, if you're already sick to begin with, or having other things going on, you're much likely to have a higher lactic acidosis. It is interesting, I mean, he was found unresponsive, right, in the vehicle. So we know he's going to be not breathing for a while. So that's going to cause some hypoxia and things to set up to worsen that lactic acidosis, okay, as we see that metformin progress. So the problems that we're up against looking at this: metformin-associated lactic acidosis, refractory vasodilatory shock, things it may not like a lot of our efforts to improve that blood pressure when it changes or increase the tone in the vessels. I thought that was a little scary if you don't have any tone. Granted, we can add it, but hyper or hypoglycemia, and then children in 1 to 2 tablets equals an overdose, essentially, especially in some of these drugs. The other factor that we already talked about was extra pills. Unfortunately, his were in a bottle and unlabeled, which you can Google, right, the size, name, and find the tablet. In this circumstance, when my partner and I walked in, looking at metformin, he was actually very, very sick. So there wasn't quite the time to look up the pills yet, or call poison control before we could make a lot of changes. But long story short, this is my slide of what we're all heading to do this summer because it makes me happy. But we're essentially heading uphill because we don't know what those pills are. We don't know what else he got into. Oftentimes, if you're on metformin, there's a high likelihood, right, that you could be on a beta blocker or some other chronic condition medication, right? That's the known thing. So I wish we could go take that walk and, right now. But coming back to acidosis, and before we continue with this kiddo, just remember when we talk about metabolic acidosis and the interventions that we do, it doesn't always apply to every other intervention or patient condition, right? And I know that seems a little silly, just working with our clinicians and different clinicians around, I notice that sometimes we can extrapolate too much from acidosis, especially in kids, okay? So this patient has a known acidosis. We're expecting him to have an acidosis, well, because of the metformin, and then we did a blood gas at the bedside that showed he was acidotic. So a lot of times, let's say this kid was intubated right when we walked in and we put him on a ventilator. The most common phrase I've heard is to put them on a ventilator at whatever they were breathing before, right? I think that kind of pigeonholes us in a lot of pediatric cases because maybe a kid with a fever that's breathing fast is not in metabolic acidosis, right? And so we can cause a lot of problems with that. So as we talk about it, just approach it with caution, right? And understand, are we heading down the metabolic acidosis path? What are we looking at here? Is it separate? It's separate from our respiratory acidosis, alkalosis, okay? So bringing it back to those initial keys of position, suction, warmth, oxygen, and expediency. So now we'll get to the bedside and tell you what we did. I have a couple slides on here because the first one might give you a heart attack. So you walk in, find out about the metformin. So we know we're going to check a blood sugar, and he is unresponsive and obtunded. And so the PA at the clinic has just intubated him successfully, and we get an end tidal and there's color change. Partner goes to check the blood glucose. I think, well, let's put him on the monitor so we can get going. So what was our blood pressure? Yes, nothing, right? So I hesitate even calling that a blood pressure, right? Because by the time that we cycle it and look at it, and I'm getting that information, I know he looks terrible. So the question is there time for fluid? What do you think? Yeah. Do you guys have push dose epi? Anybody have it in their protocols to give push dose epi? Yeah, a few. Okay. What?
I put my hand up.
Oh, okay. Right? Okay. Bolus epi with I'll ask you about it after, but it's a great thing. It gets you out of those spinny, heading towards not good things situations. So there actually was fluid hanging, but it was just wide open. Ideally, I'd put it on a pressure bag, but my decision at the time was, well, let's go ahead and just give push dose epi. Because when we look at that, and by the time we get to our intervention, he could be in an arrest state. Okay. I do think one concept that we don't talk about enough in EMS is we get very good at ACLS and PALS and BLS and what to do when the code is occurring, but not quite before the code, right? So we have to recognize those peri-arrest states and start doing something about it before we end up in that pathway, okay? So I gave a little bit of push dose epi, worked, and it worked in about 30 seconds. Obviously after that, I grabbed the fluid bag, put it on a pressure bag. But right then, we're avoiding getting to that point of PEA in this case, where he has no tone. I want to talk about epi infusion or PACE versus non-PACE. So the second slide here I included because that was shortly after the push dose epi. I'll tell you, it was fast. By the time I looked at the monitor and I see 40, 30, or I just see things spacing out, I'm thinking that is not good. Give your push dose epi. And then it corrected it actually to the bottom one. So it's pretty impressive. And they were spacing out quite a bit more. I didn't even have time to figure out if there was a P wave, what was going on. I thought, this is not good, okay? But pacing, who would have paced this? And there's no wrong answer, that initial one. No?
It wouldn't be a advantage for something too quick.
Yeah, for sure. The spoiler, right, I guess, is if your epi works, then continue that. And I think that was the easiest answer at the moment was push dose epi is working. So let's start an epi drip, right? The other thing I wanted to point out, so with pacing, it will help for a moment and even the epi, but really in these cases, in that peri-arrest state, we need to be looking for those reversible causes. Obviously, we can't take all the metformin out of his system in this case, but ultimately, that's what we need to get him to, is to see what we can get out of his system to be that reversible cause. In this case, for his size, I went ahead and started a 0.1 mic per kilo per minute drip of epi, and it maintained his heart rate. The key, I want to say on heart rate, because his was 55 to 60. I got a little nervous when it was in the 30s, right? Because younger, healthy male, you think, okay, yes, we can be a little bit lower, but the key was that lack of tone and a blood pressure that I'm seeing that's not good. So even if that were 60 or 70, I still would be giving that push dose epi because there's no tone. Is anybody wondering about bicarb in this case? A little bit? Oh, then you said I was, or I then started reading about it, and same. I've seen it a handful of times used. Obviously, we see it used in code situations a fair amount. It's controversial, which is the best word for it. It can cause some of these things, which is why it's controversial. It's usually recommended when you have a pH of 7.1 or lower. We had that luxury of an iStat at the bedside to see what his pH was and what we were working with. We didn't know we knew the potassium, but the nurse didn't take that potassium with her to put it in the chart, but it was normal. So in a nutshell, this gentleman was intubated for airway protection, first off, okay, right when we showed up. He had fluid resuscitation, and I should put in capital letters, push dose epi. And the other piece that you were probably wondering was the dextrose, or glucose. So we checked his blood glucose, and it was 33. So easy answer was we gave an amp. Long answer was in about 30 minutes by the time we were at the receiving. So we checked about 15 minutes later, it was like 300. 15 minutes after that, it was back down to 90. So it was very high consumption. I mean, in my opinion, that's just opinion based, but pretty fast. So we continued vasopressor support. After that initial little bit of tone, his blood pressure maintained pretty well, actually, to the point we were decreasing the epi. He just needed a little bit really for that tone. So truly the heart rate probably wasn't the problem initially. It was that low blood pressure and no tone eventually causing that hypoxia and PEA, okay? So once we supported the tone with the epi, his heart rate was fine. The last answers, rapid transport and consider hemodialysis. So to get that metformin out, we can dilute it with a little bit of fluid, but that only goes so far, right? Especially if the kidneys are working, all that. Receiving vital signs. So I feel like that's my report card to you. Just kidding. Better. Yeah. And ventilation, if you guys want to chat about that one. So we did consider his end-tidal CO2, consider it for metabolic acidosis, do a winner's formula with the info that we had, and maintain that minute ventilation so he could balance out his pH. So that's why his end-tidal CO2 was a little bit low based off of the bicarb I had from the sending facility. It's not an exact science, but we were just blowing off a little bit of the extra. I was able to basically decrease the epi. I already told you guys that. And then consider hemodialysis. That's a lot. Your takeaways though, for at 3 a.m. if you ever run into this, then I hope you don't. Okay. Because that's why we talk about these things, right? Because we do something once, we see it again the next time, and oh, we already did that. Oh, that lady mentioned this that one time, and they just gave epi and fluids and checked a sugar and gave dextrose, and everything was fine, right? So don't bet too soon, but I think we all know that on what the outcome is going to be, or what you're going to see from your patient. Because I was ready, I was trauma-based. Let's get this trauma going. I would have given fentanyl and RSI before I even looked at the patient. Remember the increasing availability of metformin, all ages. So high likelihood that any little kid can get into it. So even, you know, if families, it's hard because they don't think about those things, and that's why just lock up your meds, right? Do the best, keep them high out of reach, but metformin is available everywhere. So high likelihood that it will happen. A little medication in these tiny bodies is a lot, so it doesn't take very much. Okay, granted this kiddo took a whole bottle, but they have more heat loss, excuse me, and increased oxygen use because their metabolisms are just so high. Hence the sugar, you know, going so high and then going so low. And then recognize peri-arrest. Okay, I will tell you a story. There's one time it was a COVID patient a couple years ago, and the blood pressure kept doing this, and I was chasing it with sedation. I'm like kneeling over in the fixed wing, and my partner said, you know, because we were nearing a code, and he looked at me and he's sassy. He's like, "You must have not been in a lot of these situations before." And I was like, okay. I looked at him. I said, because I work really hard to avoid them. I don't want to be in the code. I'm gonna try to avoid it. So just remember, peri-arrest is a thing. Push dose epi. Any questions? No? I can't tell if that's a good or a bad thing. Yes.
So we talked about glucose and peds with metformin. Can an adult also do the same thing?
Definitely. Yeah, it's just going to be the ratio. Poison control is great at that. So get knowing the quantity and the kind of metformin, or excuse me, the kind of drug that they're on, just knowing quantity and drug, and then the body weight. They can definitely help with those rapid calculations to anticipate what is going to be needed in the next 24 to 48 hours for that patient. So yeah, definitely can happen in adults.
So the part of the job that I don't like is not knowing the final outcome. So how did this child end up?
That one I don't know.
Are you serious?
I'm dead serious. I know. But I'll check on it. I'll check on it and follow up with you. Yeah, this was it was definitely a difficult situation, and a lot of continued calls after that. So, yeah, I know it's hard. Now that I let you down, you can talk to Carrie and be brought back up.
Thank you.
Yeah, thank you.
Thank you, Shelley. I'll see if I can run this clicker. Yes. Okay, we're going to switch gears a little bit. We're still on the helicopter. This was a flight that we did. In fact, it was one of our educators and her partner on this scene. So what we get on our pagers are, you have an on-scene request. We figure out where we're going to go to, whether it's adult or peds for the trauma center. We did hear it was a trauma, and it's a 2-year-old, so that's all we know. So like, oh, this could be interesting, right? So going with that, how do you all prepare for a call, whether it's pediatric or adult? Talk about it, okay. Anything you use? Yeah, references. So, and the key is to prepare, right? You guys have heard the adage of failure to prepare is preparing to fail, right? So especially with pediatrics, age appropriate equipment and then medication doses are everything. So use your references. So I may have prepared too much back in the day. So if I would have gotten this call and I knew I was getting a 2-year-old, I would have, in fact, one of the calls I was on, my partner and I got a call for a 6-year-old ATV accident. Great, I look it up, I know the weight, I know all the doses, I know all the medications I'm gonna give, I know the equipment sizes. We walk up to we rendezvoused with the ambulance, open up the doors. I'm like, he's not 6, he's 12. Look at my partner, I'm like, double everything. So don't get pigeonholed into it has to be that age, right? So that's why our references are so important, because things change. Reports change, right? Because they're changing hands, right? So it's kind of like that telephone game. Sometimes you miss something in each part of that communication. So since then, make sure you just have I always have a good reference on me. So use your references. You guys mentioned hand heavy. I don't disclose, I don't have any preferences, but as long as it's handy on your person, it's up to date, use it, because hand heavy, Broslo, PDStat, any app, anything you have on your person, that decreases that cognitive loading that we have on the scene. So if we can offload some of that, it's easy. So use it. So here is our patient. He is a 2-year-old male. He was restrained in his car seat. He was involved in a high-speed head-on collision with another small SUV. He was found hanging out of the front seat passenger window, still restrained in his car seat, but his head was hanging out the window. Yeah, so what are you thinking? Must not have been, right? Or not hooked in appropriately, which we see that sometimes, right? Yeah, so the very first vital signs are right here. Blood pressure, you can read that, 72/38, heart rate pretty tacky. Respiratory rate, he's still breathing, but it's shallow, and his sats are 94. So what do you think of those vital signs? Pretty good? No? So how do you know what's normal for this 2-year-old? References. Exactly, because if you don't know what's normal, you might not know what's abnormal. And there's such a huge variety for peds, right? You can go 3 months to 13 years, like Shelley's patient, right? Pretty much an adult. We all pretty much know what the normals are for adults, but for kids, use your references to know what's normal. So what kind of injury are you thinking with this? I just gave it away. There it is. Yeah. So he did have obvious head trauma. He had a huge scalp laceration that was actively bleeding. It was controlled, and he was altered. So with traumatic brain injury, initial versus secondary. And when I say initial, no matter what happens when that initial traumatic moment happens, there could be us right on scene when it happens. There could be a neurosurgeon on scene. It could be an ER doc, everybody there when that initial injury happens, but we can't change anything, right? What happens, happens. But what we can have a huge impact with is preventing the secondary injury, right? And we're going to talk about 3 things. You've probably heard them before, so it might be a review, but 3 things that we can do with things we already have. You don't need extra supplies, extra protocols, but the 3 things we can do to literally save the brain. So this is a very, very interesting pre-hospital TBI study, the EPIC, which is the Excellence in Pre-Hospital Injury Care. So what they did, they trained over 11,000 Arizona EMS providers. They were trained in these treatment guidelines. For any TBIs, these objectives, you are going to treat SATs over 90. You are going to treat if the systolic blood pressure is less than 90. So basically think 90 and 90. The SATs are below 90, treat. If the blood pressure systolic is less than 90, treat. And if you're monitoring entitled CO2, keep it 35 to 45, which is normal. That was the education, right? They didn't need anything extra. And they had over 22,000 participants in this study. Huge, huge study, super interesting. So in the study, they also found that this TBI severity score, which is injury severity score, found that in the moderate injury severity scores, they had a low death rate. In the critical, of course, they had a high death rate. But in the middle, where it was severe, that's the part where we, as pre-hospital, can have the most direct effect on the outcomes. And this is actually what this study did. It was one of the first evidence-based studies to look at the direct outcome of using these after educating the EMS system. So this is the study, the EPIC TBI study was done from 2005 to 2017. This is a recent update. This is very interesting. They found that for adults, the systolic blood pressure is way higher than 90 to keep perfusing the brain. In fact, they found systolics of between 130 and 180 to be supportive of outcome. Can you imagine 130 to 180 for a trauma patient? The big takeaway from here is you do need to follow your local protocols. But again, remember, with traumatic brain injury, you need more blood pressure to perfuse that brain than you would normally. So these were the outcomes. If the patient was hypoxic, and I mean one episode of being 89%, 82%, 78%, they had 5 times worse outcomes. If the patient had one episode of hypotension, 3 times worse outcomes. When those two are combined, that's where it really hits home. Then it just multiplies. So really what you can do, keep these patients oxygenated and keep them perfused. That is really what it's all about, because when those two come together, bad things happen. So I thought that was really profound and actually pretty amazing. So avoid the H-bombs. You might be saying drop in F-bombs, but avoid the H-bombs. Has anybody heard of these H-bombs? Yeah, it's not new, but it's a good thing to remember. Again, we don't need any new equipment. You're probably already doing this, but the point is to be aggressive with each of these, right? Avoid hypoxia, avoid hypotension, and avoid hyperventilation. And we'll talk about each of those. So number 1, prevention and treatment of hypoxia. So what if my patient is 94% on room air? They're above 90. Let's say this 2-year-old, he was 94%. Does that 2-year-old, does he need oxygen? Yes, absolutely, right? We're going to give him all the oxygen. In fact, I probably want him to be 100%, because what we want to prevent is any further desaturation. Yes?
As a PHTLS, it was proven that oxygen-free radicals cause problems as well. So when you're coping less than 100%?
Well, that's a really good question. For the short term, and I haven't seen a lot of studies that show those free radical damages in the short amount of time for pre-hospital transport. But that is something for long term. But with traumatic,
Our goal is first do no harm.
it is to do no harm. But if, again, the studies have shown if these kids, if they have one episode of hypoxia, it can worsen their outcomes. So the whole point is to give a lot so they don't have a chance to desaturate. And that's just for transport, pre-transport. So if you can, always avoid the hypoxia, non-rebreather, right? All the flow, put it on, it's okay, right? They can titrate and figure that out at the hospital. But you just want to prepare for that unexpected crash. You don't ever want to be behind the 8 ball. So intubate or not to intubate? Would you have intubated this 2-year-old? Shallow respiratory rate, he was working a little bit. Definite head injury.
You run the risk of aspiration.
Okay, anybody else?
can also push their weight.
Yes, exactly. Honestly, you know, intubate if you have to, of course, right? If they're showing signs of not oxygenating or ventilating well, you do what you can and with it, what's within your scope. But if you have to intubate, think about what that can do, right? Think about if you have to RSI, you have to do a lot pre-oxygenation, right? You're going to give them medications, which could further make them hypotensive. It might increase them to be hypoxic more, just the whole process of RSI. But you can always use your bag valve mask with an OPA. You can put in a supraglottic.
NPA.
Absolutely, NPA, OPA. NPA maybe depending on the, because he did have some head trauma. So maybe OPA. But whatever you decide to do, you do not have to intubate, but just think of the ramifications if you do and be prepared to take care of those before you do it.
But I would definitely do the airway.
So if we intubated, or you put a supraglottic, or you're bagging with this patient, what rate would you start with? It's up there. I know I gave it away. Right? Are we going to, do we want to bag really fast? We really don't, right? So where do we start?
20 minutes.
20 a minute, sure, I love it. Something that's age appropriate. Then you can get a value and then you can titrate from there. So there's three things in our cranial vault, right? We have our brain, we have CSF, and we have blood. So what's one of those things that we can control? The flow of the blood, right? So if we are ventilating too fast, breathing too fast for them, what does that do to the blood flow to the brain? Vasoconstricts, so it gets less blood flow. So that means it doesn't perfuse as well. In the old days, we used to hyperventilate everybody, but now they're seeing that that's not beneficial. We're not getting any flow, and if we're not getting flow, we're not getting oxygen. So that hypoxia and hypotension just goes hand in hand. So if you can keep them normocapnic, meaning 35 to 45, just keep them in that range, because this study has shown that the outcomes are better when they're not over ventilated. And it's really easy to get on scene and just, right, because you get, I mean, I'm as squirrely as anybody else. So sometimes you have to use somebody else. Look at your, you might have to have like a spotter on your entitled to make sure that you stay within those ranges. So pediatric BVMs. How much volume does a pediatric BVM hold? 5, you guys are so smart. You guys are so smart. Yes. Yes. So it's a lot. There's been a lot of studies about lung protective ventilation, and kids and adults, really what they need is 6 to 8 mils per kilo. You don't have to remember that. Just know that there is no way that any pediatric patient needs that whole bag squeezed. So what is appropriate for him as far as volumes is about 100 to 120. So what that means is you squeeze the bag just a little bit till you see some chest rise. So don't get over aggressive with that, because you may be bagging at an appropriate rate, but if you're giving huge volumes, you could still overventilate that way. So just something to think about. All right, we talked about hypoxia. Now we're going to talk about hypotension. So when you have head injury plus multi-system trauma, what's your goal blood pressure? What about permissive hypotension? Anybody? Okay, so the whole idea of permissive hypotension, right, is to not, not disturb the clots, right? Keep with the clot formation, right? But if you have multi-system trauma with a brain injury, the brain injury wins. The brain is the organ that we need to perfuse the most. So Permissive hypotension doesn't count with that. So we want more blood pressure, more systolic blood pressure, so we can make sure we're perfusing the brain. Above 90. And we'll look at that. So for pediatrics, and this is actually in our protocols. So most all AHA references for pediatrics is 70 plus the age times 2. Right? That is their normal blood pressure. Well, if you look on that scale, normal blood pressure, that's in the bottom 5th percentile for kids. Bottom 5th. So if you're already close to the bottom 5th of the percentile with their normal blood pressures, you are behind the 8 ball. So we changed our protocols to be 90 plus the age times 2 because there's literature to support that. So that way we're not close to that bottom, kind of falling off the edge there. Because you know kids, right? They're normotensive until they're not. So think always a little bit higher blood pressure to perfuse the brain. Think 90, age times 2. So this kid would be around 94 to 100-ish. So we talked about hyperventilation again. Remember, we control the blood flow to the brain. So make sure if you're the one bagging, or if you're watching somebody bag, make sure they're looking at that respiratory rate and the entitled CO2 to keep them in the normal range, 35 to 45. That's it. That's it. No need to go higher than that. Who here has entitled CO2?
We have it, we just don't use it very often.
Yes, and you can use it even on if you have to bag valve mask, right? Put your entitled, do you have that, it'll fit right into your mask and your bag there, right, in between? Use that. That is an amazing thing to use. If you don't have it, please beg with your MPD to get it for you, because this tells us everything, right? And the great thing about this is it'll show us our entitled CO2 value, right? And then it'll show us exactly how quick we're bagging, right? That respiratory rate is usually right under. So I can't stress using this enough. It'll keep you within the range or help keep you on top of whoever's providing ventilations. Use a spotter. Again, if it's a busy, chaotic scene, have somebody just dedicated to making sure that CO2 stays within 35 to 45, right? Again, we don't want to have overventilation, which typically happens. I read a study, it was a while ago, and the average bag valve mask rate, respiratory rate on a code was in the 50s. Crazy, right? But I can see it. I mean, I'm the same way. If I'm not concentrated on just that, I'm probably bagging way faster than I think I am. So really, really important. Okay, so what did we do when we got there? So here's this kid. He's hanging out of the car window, obvious head injury. He's altered, at a GCS of about 6 to 7, I believe. So what we did is, wow, okay, we're gonna have to take over his airway. He was breathing at 22, but shallow, but we had quite a long flight, so our decision was to take over his airway. So before we did that, we thought about, we put the high flow oxygen on him, that's going, but we knew that we had to resuscitate him before we intubated him. And why is that? Because once we give him medications to intubate him, plus the positive pressure from the bag, that is just going to decrease his blood pressure even more. So we want to tank him up before we do any of that. So we started an LR bolus, 20 mils per kilo, whatever that is, and push dose epi. We didn't give it, but we had it ready. And we did think about blood too. It's not as, we had the LR much more available to us. So we started the fluid and then thought about blood. So we utilize an RSI checklist, which is a handy little tool for us to make sure that we don't miss anything. We don't miss positioning. We don't miss getting the suction out. We don't miss getting the entitled CO2. We don't miss checking the doses with our partner. It's just a quick checklist to make sure we're doing everything right for the patient. So we pre-oxygenated. We had a non-rebreather on, and then we had a nasal cannula at 15 liters, right? We were giving him all the O2. Intubate him with a 4.0 cuffed ET tube. A plug for the American Heart Association, the 2020 updates, they recommend any pediatric patient that needs intubation always gets a cuffed ET tube. Always, always, if you have them. Finally, yes, yes, I love it. And then on our card, it gives us a clue of right after we intubate, secure the airway, we have to think about post-sedation analgesia, those kind of things. And then, of course, we're going to use lung protective settings, meaning volumes that aren't too big and rates that aren't too high. So we did give that fluid. We ended up giving some blood as well because he was bleeding blood. And if they're bleeding blood, give them blood if you have it, right? If you don't, use fluid, isotonic fluid, or push dose epi if you have it. Anything to get that blood pressure up, right? So this kid's blood pressure goal was high 90s. So these are his vitals. What do you think? Yes.
The heart rate's dropping.
Yeah, why do you think the heart rate dropped? Good, good. Yeah, I really hesitate to think. I can't imagine this blood pressure would be that good if we didn't tank him up before we intubated, because that can make a huge difference. So the big takeaway on this intubation, you don't have to do it. You don't have to intubate. You can take over their airway via bag valve mask, supraglottic, whatever you have to do. But if they're in respiratory failure, of course, do it. The big thing is make sure you're providing oxygen, right? Make sure you're keeping that SpO2 over 90 the whole time. One thing that we did too is backboard elevation. What do you think that did for a suspected head injury? Yeah, right? Elevate the head, right? It might increase more drainage to decrease any suspected intracranial pressure. Good. That's something that you can do very easily. We maintain the oxygenation. Again, we're going to keep him at 100% till we get to the receiving facility. We did give him blood product, which I think he needed. Sounds like he needed it. And we did some neuro checks. We went to the nearest pediatric trauma facility, and he actually did remain stable. We were able to give him some fentanyl and a little bit of Versed. So the keys on this, can't stress it enough, to prevent that secondary brain injury. Again, we can't prevent the primary, but we can prevent the secondary. So prevent desaturation. Oxygen in the short term is good for these traumatic brain injuries. Prevent hypotension, give them fluid, give them blood, give them epinephrine, something to get their pressure up and to keep it up. And avoid bagging too fast. If you need to, have a spotter to keep you in check, to keep that entitled CO2 in the normal range. So this 2-year-old was diagnosed with a head bleed, but he was in the hospital for quite some time, had some surgery, and he has no neurologic defects, and he's doing great. So that's exciting. Big success for us, absolutely. Any questions?
Nice to know the outcome.
Yeah, it is.
Yes, yes.
Thanks for leaving me hanging, Jill. So they can hear it.
Yes.
So I can't see the questions. Let me see.
It says, why is it so cold in here? No, just kidding.
Pediatric BVM refers to infant or child BVM.
Oh, so there's a good question. It says pediatric BVM refers to infant or child. So pediatric is not infant. It's pediatric or child. There's a separate neonatal one, which is really small. It's kind of adorable, but it's really small. So the pediatric is everything down to the everything up from the neonatal one.
I did have a question as to whether the first case was a suicide attempt, and yes, it was.
Oh, good question.
Yes.
In the second scenario.
I'm sorry?
At what point in time do you move the child from the car seat in the second scenario?
Well, we did as soon as we could. We maintained C-spine as well as we could and just got him out of there so we could have full access to him. It's a good question.
About taking say the second scenario.
Ooh,
What was the-
TXA. We don't currently carry it on, right now. It's something that we're looking into, but that's a really good thought. And that would be the perfect time to do it. It's less than 3 hours within of the injury. Yeah, it's a great thought. It did seem like his bleeding was mostly from his scalp, but who knows with internal, right? So good thought.
I think we got all the questions online. New at this?
Yes. All right, thank you, everybody.
Sorry.
Enjoy lunch.
Thank you.